Hello, everybody. I want to welcome you to the satellite session on the use of routine health information system data for research and decision-making. My name is David Hotchkiss. I'm from USAID's Data for Impact project, and also I'm a faculty member at Tulane University's School of Public Health and Tropical Medicine in New Orleans. And I'm co-chairing the session along with Michael Law of the University of British Columbia, who you'll meet later. This session is sponsored by USAID's D4I project, and D4I is a 5-year cooperative agreement funded by USAID. It's led by the University of North Carolina at Chapel Hill, includes Tulane, but also a number of other partners. And D4I seeks to achieve a number of results, including building strong evidence for program and policy decision-making, building individual and organizational capacity for research and data use, and enhancing data use for improving global health programs and policies. Next slide. Just to give you a next slide, just to give you a little bit of background for the session, accurate and timely information on the health needs and health service utilization of populations is a critical element of health systems, and such data can be used not only for program monitoring, but also evaluating the effectiveness of programs, allocating scarce resources. And administrative data is increasingly available in a lot of countries. The DHIS2 software, which is a web-based open source platform, is now used in 67 countries, including many in Africa and Asia. And given that RHIS is an emerging source of data that can be used for big data analytics and evaluations, they have a lot of advantages. They're considerably less expensive and time intensive than conducting household surveys. But despite the increased availability of these data systems, they remain relatively underutilized for health systems, research, and evaluations. And there's a number of reasons for this, mostly due to concerns about the quality of the data. Sometimes they're viewed as being incomplete or having potential for measurement error, which can bias estimates of impact. So consequently, most impact evaluations on service utilization and health outcomes utilized population-based household surveys and bypass routine health information systems. Next slide. So this panel session will focus on 2 topics in order to learn more about RHIS data quality and how it can be used for research. The first hour, we're going to focus on country experiences in strengthening the quality and use of RHIS data. And we have 5 health informatics and RHIS specialists who have played leadership roles supporting country governments to strengthen district and facility level data systems, and they'll share their experiences and lessons learned. And each of them will give a short presentation, and we'll have time for questions and discussion afterwards. And then in the second hour, which will be led by Michael Law, the second hour will focus on the use of RHIS data for health research and evaluation. And we'll hear the results and experiences of 4 researchers who have used RHIS data as the primary source of data in recent health system studies, and the session will explore the methodological and practical challenges that they face using this kind of data. And we'll also provide opportunities for participants to share your experiences, ask questions, and providing your recommendations. Next slide. So I sort of summarized this already, but the overall objectives of the session are really just to share experiences of our RHIS strengthening experts and researchers, to share some of the challenges faced and lessons learned, but also to provide an opportunity for you to share experiences, and then also providing increasing networking opportunities for researchers, specialists, and health system planners from around the world. I've met a lot of our participants through planning this session, and I'm hoping this is going to lead to more networking between RHIS specialists and researchers. Next slide. So let's go ahead and start this first hour on country experiences. We have, again, a very impressive group of 5 informatics specialists, and each of them will have about 5 to 6 minutes to present their presentations. And we're going to go through all the presentations And please, I would encourage you to post any questions you have in the chat box on the virtual platform. And Michael and I will keep track of those, and then we'll go through as many of those as possible at the end of each of the first hour and second hour. Next slide. So I'll go ahead and introduce the first panelist, Derek Kunuka. Derek is a senior health information systems advisor at John Snow, JSI. Derek leads the HIS approach for USAID's Country Health Information Systems and Data Use Program, and previously led bilateral and regional RHIS strengthening projects in the Southern African region. He will share approaches to RHIS capacity building at the country level and through regional networks and platforms. Derek?
Thank you, David. And thank you all for joining us today for this conversation on approaches to routine health information systems capacity building at the country level. Thank you. I will talk about strengthening RHIS capacity using multiple funding streams that we did on the Measure Evaluation project. I will also share reflections on trends in country demand and recommended areas for future investment. I will elaborate on regional networks later in the panel discussion. We've packaged the strategies in 4 areas: development or customization of information system platforms for program monitoring, deploying or scaling of information systems, strengthening capacity to manage country HIS, and then interoperability of systems. I will now share a few examples starting with Mali. Next slide, please. When we started working in 2013, there were 9 parallel standalone non-networked systems, no reliable communication network for information sharing, and limited electronic reporting functionality at subnational and health facility levels. Through our work, 9 systems were integrated into DHIS2, reducing reporting burden and improving timely response to disease outbreaks. Electronic data entry now begins at facility level. There are built-in data quality checks, and the system has decision support, which has enabled a shift from quarterly to monthly reporting, making quality routine data available to inform decisions. In 2013, timeliness of data reported via the old DSAM system averaged 17%. By September of 2018, data timeliness via DHIS2 averaged 65%. Next slide, please. In Madagascar, we started with multiple vertical program-specific reporting systems and disease surveillance systems. Coordination of HIS partners through the governance body, the TWG, produced an HIS roadmap that paved the way for development and implementation of SOPs, tools, guidelines, a DHIS2 action plan and scale-up strategy, data quality assurance plans and assessment tools, the national HIS strategy itself, as well as a coordinated deployment of DHIS2. In a data quality review following deployment, we were tracking data correctness at 63%, completeness at 95%, and timeliness at 84%. Moving on to Burundi, we were met with multiple siloed data collection systems. Next slide, please. For routine data, HIV/AIDS data and community-based data as well. After DHIS2 deployment, data entry was occurring in all districts and hospitals, and 80% of the health centers nationwide. We supported the integration of the different data streams and strengthened capacity to collect, analyze, as well as disseminate this data. Next slide, please. At the start of our support to Côte d'Ivoire, data collection tools and data accuracy were absent. There was no national data warehouse and no accurate and timely routine reports for decision-making. Aggregated data was not interoperable across health sectors, and early warning systems for detecting emerging infectious diseases were not in place. We assisted with the interoperability of these existing systems through the DHIS2, which became the primary HMIS in the country. We also strengthened community-level data by piggybacking on DHIS2 deployment and developed software applications that enabled integrated reporting of disease threats, mobile capture of surveillance data, and exchange of information relevant to decisions being made in real time. In response to Ebola, we strengthened epidemic surveillance by developing an early warning system and integrating it into DHIS2. Next slide, please. Cote d'Ivoire's experience is a good segue to our first reflection, that there is a capacity gap between IT and health program managers. There is a huge demand for go-betweens to interpret the data needs of program managers into the ICT operations and vice versa. We found that stakeholders collaborate on design of the architecture and deployment of systems, but data synthesis and use is still very limited. And what do we see as the trends in country demand? Obviously, the first one is customizing existing platforms, especially the HMIS installations. Countries simply cannot adjust their processes to suit systems fast enough, and so place their bets on customization of systems. Secondly, intensive data verification and monitoring of data quality, especially at the facility level, to support and improve data use is a big demand. Since data availability has increased, there's now demand to verify that the data are of quality. I already mentioned the gap between ICT and program managers. And lastly, these disease-agnostic tools that are standards-based are in big demand versus those tools that are spurred by specific interest and earmarks, usually from funders. Countries are requesting tools that cut across all health areas. Last slide, please. We therefore suggest the following for future investment. Firstly, metrics to measure systems deployment and process to scale. We had numbers to track increase in number of HMIS users, but we just don't have coverage numbers because in many cases, the denominator or optimal number of users is undefined. This enables a comparison and lesson sharing by countries at regional platforms. Secondly, to continue to support interoperability of systems is key. Third, with changes in electronic systems and advancements in responses to diseases and health conditions, continuous training on these new electronic systems is essential in order to maintain, update, and respond to the various system challenges and changing user needs. Finally, we recommend monitoring the performance of the country coordination mechanisms to ensure continuous improvements and HIS progression that is pivotal to regional discussions. Thank you.
Okay, thank you very much, Derek. We'll go on to the next presenter, Netsanet Anamut. Netsanet is a technical director at JSI. He works for the Ethiopia Data Use Partnership Project. He's an experienced RHIS professional with 17 years of information systems experience in the health and education sectors, and was the lead technical advisor of Ethiopia's Connected Wareda strategy, which will be the focus of his presentation. Netsanet?
Thank you, David. I will be presenting an overview of the Connected Wareda strategy that we have been implementing in the last couple of years to operationalize the information revolution agenda of the health sector transformation plan in Ethiopia. Next slide, please. The information revolution is one of the priority transformation agendas of the health sectors, along with 4 other transformation agendas like HR, finance, quality and equity, as well as primary health care transformation. The goal of the information revolution is to bring the cultural transformation in the use of quality health data, which we believe will lead to improvement in health system performance and with the end goal of achieving better health outcomes. The information revolution strategy was developed 5 years ago and continued to be a priority of the health sector in the next 5 years strategy, which was launched last week in the health sector annual review meeting. As you can see from this slide, the information revolution has 2 pillars. One is bringing cultural transformation in health data use, and the second one is digitizing and scaling up priority health information systems like the DHIS2 that Derek was mentioning in his previous presentation. And there is also a foundational component, which is improving the governance of health information system. By comprehensively implementing these two pillars and the foundational governance component, we believe that the connected districts can be created, which are models in information revolution and consists of the Warada or the district health office and the health facilities available within that specific district. And the improvement in health data quality and use will gradually lead to transformation in other health sector priorities, like in quality, equity, and other priorities that are articulated in the health sector strategic plan. Next slide, please. The Connected Warada strategy was created a couple of years ago to operationalize the information revolution agenda at the district and health facility levels, which was needed because it was difficult to implement that strategy based on the broader high-level objectives that are set in the strategic document, which is difficult to actually go out and implement. And this is Connected Warada strategy helped us in operationalizing it. The Connected Warada concept was later expanded to include hospitals. As you know, the hospitals generate huge amount of data, and focusing implementation of information revolution at district level only may not necessarily bring the required change in the broader health data quality and use. That's why we helped the Ministry of Health to expand this concept to include hospitals that are outside of districts. We believe that changing the data use culture at the district level has a catalytic change factor, and changing the district health office will lead to better data quality and use in the health facilities within the district, as well as at the higher level in the health system, since most of the data is generated at the district level. And in the 20 years envisioning the document of the Ministry of Health, the plan is to go beyond the district and create a connected nation. And this Connected Warada strategy has been implemented in the last 2 years in particular in 44 districts. And I will present later the results in the 8 districts that we are being supported by the Data Use Partnership Project. Next slide, please. As you can see from the graphics in this slide, the end goal of the Connected Warada is creating a two-way digital care network, starting from the health post, where the health extension workers provide community level services, all the way to the specialized hospitals. And it's mainly about the referral linkage and sending back feedback from the highest level in the healthcare hierarchy to the lowest level. It also includes a two-way information flow, all the way from the health post at the community level to the Ministry of Health at the national level. And as you can see, everybody starting from the community, administrators at different levels, starting from the district to MOH, to all and healthcare workers and supervisors at health facilities will benefit by having these connected districts and health facilities in the healthcare system. Next slide, please. The Connected Warada strategy actually starts with an assessment, and there are 4 major components of the assessment, which is actually based on a standard tool. The first part is about the health information system infrastructure and capacity. It's about whether the health facility or the district health office has a budget, the required human resource to implement and support health information system, whether the digital systems are in place, whether there is connectivity, electricity to enable implementation of electronic tools and services. The second component is data quality. It's about measuring all important dimensions of data quality, completeness, timeliness, accuracy, and others. And the third component is the administrative data use. We have performance monitoring team at health facilities and also at the district health office. And we try to measure the functionality of the performance monitoring team as well as the information products that are being produced at health facilities and districts. And the last component that we have developed after including the hospitals as part of this strategy are the clinical data use, the day-to-day use of health data by the physicians to improve the standard of care and continuity of care, particularly given the goals that we have shown earlier in terms of creating the digital link between different health facilities. Next slide, please. After conducting the assessment, the next step is implementing interventions, which is usually developed based using a human-centered approach. And after the gaps are identified through the assessment, various interventions will be developed by involving the actual users of the system, healthcare workers and health administrators in the health facility as well as in the district. And this, after the design, we will give it 6 months to implement the various ideas and also interventions that are designed through that process. Most of the time, the interventions are around improving existing processes or introducing new processes to use data to improve the quality of the data, capacity building in terms of training and mentorship, and also incentivizing better use of data as well as improving the quality of the data produced in that particular facility and this district. We have also various digital tools that we are implementing as package, starting from the HMIS, is the Human Resource Information System, the AMR, the Logistic Management Information System, and also the mobile health tools at the community and health facility level. Next slide, please. Within the data use project, we have been supporting the government to implement this strategy in 8 districts. The 8 districts means 8 district health offices, 41 health centers, 2 hospitals, and in total, we have 51 health institutions that we have been supporting in these 8 districts. And we have done 2 rounds of assessment, one baseline, and the second one is after 6 months of implementing the interventions that we have designed with these 8 districts. As you can see from the graph in the bottom of the slide, we had 28 emerging and 20 candidate facilities. Normally what we do is after the assessment, we grade the facilities as emerging candidate model and connected based on the score that they have got in the 4 assessment criteria. And most of the facilities and the Rwanda health offices that we had were emerging, and there were also 20 candidate facilities, and we didn't have any model health facility and also no connected facility at that time. But after the first round of intervention, we brought down the number of emerging facilities from 28 to 10 and increased the number of candidate facilities from 20 to 35, and were able to create 3 model facilities. And this has been a major improvement from what was in the baseline. Next slide, please. Again, in these 8 districts, as you can see from the chart at the top, the green bar shows facilities progressing from one stage to the next, like from emerging to candidate or from candidate to model. whereas the gray and the yellow bars are those facilities that have maintained their candidate and emerging status respectively. Practically, it means there was no progress in these facilities, and the red bars show the facilities that regressed from a better level to a lower level. Mostly this was created because of inflated baseline, but the data shows that there were facilities that have been regressed to a lower level after the second assessment was done. If you look at the data use component only, particularly all the most of the regions that we have shown progress in the data use aspect. The most challenging one was the HIS capacity and infrastructure. It requires lots of investment, and it was difficult to bring change in that area. But we have observed major improvements in data quality and use. And as you can see from the chart at the bottom, most of the regions have shown significant improvements in the practices of data use as measured by the assessment criteria that we have developed. Next slide, please. So we have three major learnings from this implementation. One is the importance of ownership and leadership from district and facility management. Unless they own the program, it was difficult to implement, particularly those components like building infrastructure, implementing system, and also having budget for health information system, recruiting the staff that will support this program require their commitment. And the second learning was an integrated approach that was evolved while we started the implementation. We started with implementing Connected Warada, but there were lots of initiatives in other transformation agendas of the health sector. So we brought together the assessment tools and also our implementation strategy, and we observed that this integrated approach brought a major change in terms of getting the attention of the leadership, as well as expediting the implementation. The last one is the importance of mentorship. We have been trying to build capacity through training for years, but we observed that mentorship, and if properly done, can bring the required change in the shortest period of time. Thank you very much. I think this is what I have.
Okay, thank you very much, Sanat. That was very interesting to hear more about the Connected Warada strategy. I see a lot of questions in the chat. Feel free to add your questions. Please make them short because we would like to get through as many of them as possible at the end. We'll go on to the next panelist, Humayun Kabir. Mr. Kabir is a senior strategic and technical advisor for Data for Impact for the University of North Carolina. And he will discuss his experiences leading a joint team composed of several USAID partners engaged in developing and implementing an electronic MIS under the Bangladesh Ministry of Health and Family Welfare. Mr. Kabir?
Thank you, David. So my slides, I will be discussing about the DGFP EMIS. DGFP stands for Director General of Family Planning under the Ministry of Health and Family Welfare, Government of Bangladesh. We have established a comprehensive routine health information system for DGFP. So I will walk you through that EMIS. Next slide, please. So this, though this is a health information system project, actually we looked at the paperwork initially, and this was done in the major evaluation phase 3, and most of the work was done in major evaluation phase 4. So at the preparatory stage, we reviewed and streamlined paper tools. And in 2015 and 16, the piloting started. And after 2 years of piloting, it went for expansion. From 2 districts, gradually we started scaling up. So still the scaling up is going on in Bangladesh. The DGFP is a big organization. They have more than 30,000 employees in rural areas. And currently about 32 districts are using the EMIS systems, and it is expected that the scale up would go on, and by end of 22 or 23 during the current sector program of Ministry of Health, we will see that EMIS is rolled out to all over the country. Next slide, please. So what is I discussed a bit about the EMIS architecture. This is a system. This is based on mostly mobile devices, because in the rural areas, you don't have electricity problem. People are mobile. They are domiciliary workers, so they're from house to house. So the tools we developed were on Android, and those run on tablets currently. And if you look at the layers, so these are actually, we start from community level, which is the lowest administrative unit of the government of Bangladesh. And there are people called FWAs, or Family Welfare Assistants, and they use registers. So whole register was converted into e-registers. So from paper to electronic, and our aim was to automate their full business process. And next we looked at their supervisors. So all the apps they use are directly connected with supervisors, which is the union or second layer from bottom. And then at the third layer, we have managers who are based in sub-districts, and they are also connected. And at the district levels, we also have tools for monitoring by managers and district managers and others. So this is organized in different layers, and all the tools are running on mobile, online or offline. And also all the software that we have used are open source. And at the top level, we use DHIS2 for aggregation. Next slide, please. And this is in short. If you look at the map, you can see that the color coding is based on the expansion from 2015. Currently, more than 10,000 users are using, and they are based in community. And we also have about 1,300 facilities. These are first line facilities providing primary care, and the data can be shared between community workers as well as facilities, and they are tracked through electronic HIDs. So, and also this is started as a pilot, but the DGFP is now providing for sustainability. They are providing funds for training, for equipment and others. Next slide, please. So I won't go into detail, but if you look at this, we have more than 25 million individuals, and these are people are lying in our database, and their records, some of their records date back to 5 years, for some 3 years. And we also have records of eligible couples. We have pregnant women's recorded as about their AMCs and PNC services, birth data, death data, and also the data, these data being shared for health insurance. And also it is providing a robust platform for research. That means that these data has proved their value. Next slide, please. And you can see that the strength of this report is that all the monthly reports now are timely and submitted at the click of a button. And this has really made the life of community workers very easy. And at the whenever it is submitted, instantly it is available in real time to all the managers and central level officials. And next slide, please. So, sorry, I had some, it's okay. I had one about the internet, the web pages of the RHIS and others, but I am finished here. Thank you.
Okay, thank you very much, Mr. Kabir. We'll go on to the next presenter, Sam Wambugu from ICF. Sam is a senior manager for health informatics. He has 20 years of experience working in low and middle income countries, and he'll discuss his experience using the Health Information Systems and Interoperability Maturity Toolkit to assess the readiness for interoperability of information systems in Kenya and why it is important for data quality. Sam?
Thank you, David. So as David has said, I'll be speaking about data quality assurance, but I will be looking at it from or using the lenses of digital health. Next slide. And I'll be looking from the point that, or I'll be speaking from the point that there is a changing landscape of information systems from paper to technology or to digital systems. And in my presentation, I have 2 points. I'll be revolving around 2 points. One is the data availability. And for that, I'll be looking at information systems interoperability. And by interoperability, I mean the ability of different information technology systems and software applications to communicate, to exchange data, and for the systems that receive that data to be able to interpret it. And in this case, interoperability may mean bringing, connecting or integrating electronic medical record systems with laboratory information systems, pharmacy information systems, human resource information systems, or interoperating data from different health programs, say HIV, family planning, and so on. And overall, countries are gradually warming up to developing data warehouses and making more and more data available for decision makers. So apart from health information systems interoperability, I'll also be talking about reviewing the data quality assessment for electronic health information systems. Traditionally, we have grown to understand and to develop competence using traditional methods of doing DQA, where we have registers and forms, paper records. But it's much more complex. Conducting data quality assessment on electronic health information systems. Next slide. So I'm drawing from an experience we had last year when we went out to Kenya to conduct a data quality assessment for HIV care and treatment programs. We wanted to validate some of the data that had been reported. And although we were well prepared to conduct DQA, on visiting the sites that were sampled, we realized that it is a little more complex conducting DQA. Why? Because there are many health facilities that are still using paper forms and registers. There are others that have hybrid systems whereby some of the data are collected using forms and registers and summarized in electronic information systems. And third, there are health facilities that are purely using electronic medical record systems. They don't use paper. But even for those systems, you can categorize them into two. Some that transfer paper data into the EMR after the fact, and there are others that are real time. And some of the challenges that we faced were some of the health facilities couldn't, the manager or the health information systems manager could not, open up the system or extract the data we were asking for. Or in some facilities, data were not available at the time that we needed it. Or the equipment, in one of the facilities, the server had been stolen. And those issues can be categorized as issues to do with technology, human resources, and processes. Don't get me wrong, there were many health facilities that were doing excellent work and collecting excellent data. But where we found challenges, the challenges were mainly related to facilities that had technology, because either there were no backup data for us to review if the original data were not available, or issues with the lack of help desk to support the users of the system. There were places where data were compromised, and that may led to us thinking that the password management system was less than optimal. There are issues to do with physical security. I've said that there was one facility where the server had disappeared, and from time to time infrastructure fails, and that can compromise the data availability. There are also issues to do with human resources, where the people to manage the systems were not enough. They were spread thin, and or they didn't have all the skills that they need to manage these information systems. So to summarize this slide is to show that there is momentum currently to migrate paper information systems in technology. In some areas, it works well. In certain areas, certain work needs to be done in terms of technology preparedness, staff preparedness, and other supportive processes to be ready before migrating into electronic medical record systems and other electronic systems. Otherwise, that shift may lead to compromising the quality of data. Next slide. Next slide. So here I'll be talking about information systems interoperability. Why is it important to the topic of data quality? It is because information systems interoperability brings information systems together, makes more data available for decision makers. And we know that one of the elements of data quality is data availability. We did this landscape assessment to see where these 4 countries in the Eastern African countries are in terms of their progress towards making their information systems interoperable. And if I have to pick from one of the countries, but really, these points I'm raising cut across generally across those countries, was that there's good momentum happening to bring information systems to a stage where they are interoperable. There were many major milestones achieved. For example, countries faced with many health information systems that cropped up about 10 years ago, last 10 years ago, they have now developed what we can call clearing houses, where they are able to review what information systems are, meet minimum requirements to join the national health information systems, and which ones do not, are not up to the mark. And also there is formation of governance structures to, look at, those resources and to help in progressing the space for, health information systems interoperability. But there still lies certain challenges. One is that, as Derek mentioned in his presentation, there's still a huge, gap between technology and health, and these 2 entities do not always come together. Yet they are so important in making interoperability possible. Capacity or human resource capacity is still an area that needs development, as well as coordination around a shared vision, because we are talking about many systems, and therefore there is need for coordination. And lastly, we found that even the terminology interoperability is not uniformly understood. There are still differences in understanding, and these issues need to be solved before the whole machine of interoperability come to fruition. Let's move to my last slide. So in conclusion, this is my summary, that thinking about data quality assessment needs to be broad. Broad because issues to do with the interoperability, issues to do with certain systems on paper, others in technology, and others in hybrid system, all needs to be considered when we are sending out a team to conduct data quality assessment. My point number 2 is that information technology, a team need to be integrated into DQA teams so that the whole process is comprehensive. Look at technology, while at the same time looking at the quality of data. Capacity needs to be built. to do a better job at data quality assessment, and gradually expand the health information systems governance structures in a way that includes IT sector into health sector, and gradually close the gap that exists between health and technology. Thank you.
Okay, thanks, Sam. That was really interesting. We have one more presentation for our country experiences panel, and that's Raymond Francis Sarmiento. Raymond is the director of the National Telehealth Center at the National Institute of Health at the University of Philippines, and he'll be focusing on the design, development, and implementation of a health information exchange system to help improve genetics disease care management. Raymond?
Thank you, David. So my title representation will be all about interoperability, very much related to the talk of Sam. Next slide, please. Thank you, Matt. So this is really a 2-year project built and started by the National Telehealth Center. Really very important to take away from these slides that we cannot create this ecosystem for interoperability without having a collaborative approach with the government, the academe, private sector, and the non-government organizations such as civil society organizations, and the medical specialty societies figure very prominently in that collaboration. Next slide, please. So this is really an electronic medical record, which it started out as an electronic medical record for X-linked dystonia Parkinsonism. XDP is a uniquely Filipino genetic disease. It's one of the rare diseases in the world. And if you have it, chances are very high that your maternal lineage can be traced to the Panay Island, which is a very small island in the middle of the Philippines. What we aim to provide here are e-health solutions to address the need for quality clinical and epidemiologic data to improve the care for XDP patients through 3 different solutions. One is an electronic medical record for XDP care through our own homegrown electronic medical record system, the Community Health Information Tracking System. We also have a mobile health application for community-based assessments and follow-ups that would allow the community health advocates. Normally, this would be comprised of the family members and the relatives of the XDP patients, and they will be the ones to go from street to street, from community to community, to be able to follow up with patients. The XDP disease becomes really debilitating in the later stages, and wherein the patient really will have a very difficult time just standing and walking around, and will need help in terms of having all of the needed medication to be delivered to him or her. But for the most part, this is really a disease that affects males really in their late 20s to early 30s in their initial presentation. And finally, we have a national registry with a visualization dashboard that reflects the set indicators for XDP-related decision-making. This is the one that's being used by the Movement Disorder Society of the Philippines. It's a medical specialty society comprised of clinical neurologists with a specific focus on movement disorders and rare diseases as related to movement disorders. Next slide, please. So specific project benefits would go into how these will be helpful to the XDP patients and their families, particularly as most of the facilities wherein they are being seen, those really employ, for the most part, a paper-based documentation and have not even seen how electronic medical record works. This also will be very helpful for the healthcare providers, healthcare workers, for efficient and effective options that will eventually replace the manual documentation, and to be able to allow for better collection, storage, analysis, and processing of patient data, for better management and for better epidemiologic analysis. And finally, for the local and national health leaders, with the availability of all of this electronic information being able to be delivered in a timely manner and very accurately, our health executives are then able to develop well-informed decisions and plans for their own local government units and for their communities. Next slide, please. So using routine health information system data really was not limited to that part for rare disease management, for genetic disease care management, but also something that we extended to COVID-19 research and decision making in the Philippines. Next slide, please. So these are the gamut of COVID-19 digital health platforms that we have. On the left-hand side, you will see COVID Kaya. COVID Kaya is a DHIS2 based surveillance platform, and it is the single digital health integration point for all of the surveillance data that we are collecting here in the Philippines. One of the top contact tracing applications that we have is Stay Safe. Also, another one which has a chatbot feature is Kira in Contra COVID. And on the far right side, we have all of the other platforms which may not necessarily be connected to the other platforms, but these work by collecting and being able to provide the information that's very, very necessary for fighting COVID-19, such as data collect, which provides the availability of all of the commodities, available beds, ventilators that we have, medical personnel who would be going on duties and who would be available, ICU beds, regular beds, temporary management facilities which will serve as isolation facilities here in the Philippines. All of that lot gets visualized in the data collect platform. We also have an emergency dispatch for emergency responders of ambulances, donation management dashboard, and also one for social welfare and development for the government to be able to provide help in the form of monetary assistance, especially to the vulnerable families, the ones who were affected and the ones who are really in the socioeconomic class C and D and E classes. You will note that not just in COVID-19, but also in my earlier presentation on rare disease care management, all of these, how do all of these connect with each other? We leverage HL7 FHIR. FHIR stands for Fast Healthcare Interoperability Resources. We set up a FHIR server in different critical points in the government, and these serve as potentially data warehouses, and they're connected to those secure data warehouse that we have, and then those serve as sort of enterprise service buses and interoperability contact points for each of the platforms that we have. In particular, we have been able to deploy earlier for rare disease care management in at least 2 health facilities right now, and we envision it to expand to multiple health facilities all across the Philippines. And then for COVID-19, being able to collect all of this information from 81 provinces, from 144 let's say municipalities that we have right now, and 44,000 villages or barangays all across the country every day in a timely manner. The reason that we are able to do that is because we have all of these platforms and also HL7 FHIR as our interoperability standard for use. Next slide, please. Okay, and we look forward to your questions.
Okay, thanks so much, Raymond. That was really interesting. We're a little bit behind, but we do have about 10 minutes for questions before we start the panel on research experiences. And I'm just reading from some of the questions, and one of the ones that have been getting a lot of attention is regarding private facilities. Does the health information system link providers, public and private, and what approach was used to incentivize private providers to utilize the system? Derek, I don't know if you want to take a crack at this, and then we can see if others want to weigh in.
Yeah, sure. So the countries that I presented on, the focus was entirely on the public health system. And it was the focus was entirely on the public sector systems that we were working with. In the cases where, I mean, I didn't present on it here, but in some of the countries where we were working, and there was a connection with the private sector and private sector facilities. Yes, that is always the biggest challenge, to encourage private sector facilities to share their data with the public system. There are issues of trust, there are issues of who's going to share, what's going to be done with that data. I think the successful ones have spent some significant time negotiating, but I'll pass on to my other colleagues in case they have a specific example that would be useful. Thanks.
Does anyone else want to weigh in here?
Yeah, just when one specific idea that we have tried in Ethiopia, it was an initiative of the previous minister to encourage private facilities to report monthly on DHIS on their service and disease data. And what we tried in small places in Addis is providing them a government-developed EMR, including the capacity building in order to use that as an incentive for them to report their data through DHIS. And we saw that.
Okay, thank you. I'm just going on to some of the other questions. There's a question, Sam, maybe you could take this. What tools do you think are the best to use for data quality assessments? And also consider humanitarian settings. Is there anything especially to use in humanitarian settings versus other types of areas?
Yeah, thank you. I haven't seen real tools that are widely available for DQA for for electronic information systems.
Mm-hmm.
For non-electronic, there exist tools out there that have been tried and used, and I can provide links to some of them. But outside of health, certain tools are used for profiling data because on data on an electronic system, you already know what to expect. If it's all, if it's about family planning programs targeting women, you expect that all data will be about women, and you expect it's going to fit within a certain age bracket. So that's basically what I mean by putting some parameters of profiling. So we can borrow those kind of tools that are used elsewhere in other disciplines and customize them for health environment to help in profiling, data profiling.
Okay, thank you. Anyone else want to weigh in on this?
Yeah, I think there was a question directed towards me from Darius Alanga, that what were the enablers for successful implementation. Yep. So shall I respond to it? Yeah. So actually, we worked with the government, and the government has a vision of digital Bangladesh, and the department was keen to have some digital solutions. And on technical side, that we could convince the users that actually what we have been doing is adding value to their works, and they saw that what were difficult to record in paper documents, it becomes so easy, and it is easy to track, and also the savings in time. So a lot of benefits actually, for which our system has gone from pilot to a scale up, and there is a strong backing from government in terms of investment, procurement of equipment, and also training other things. So overall, the policy scenario as well as the motivation from the users at the grassroots levels, I would say that has made it a success. Yeah, over.
Okay, thank you. Just going into some of the other ones that we're getting. Let's see. What steps can implementing partners take to integrate community-based health information systems collected by community health workers or volunteers into routine health information systems, DHIS2? Can someone comment on that, on integrating community-based health information systems? Derek or Sam, would you like to take a cut at that?
Yeah, so community-based information systems, always the tough one. So the places that we've seen that that there's been significant success has been where the communities themselves got involved in determining, the quality of the data. There were regular conversations with the communities, presentation of data to that communities. They had significant input into the tools that were being used to collect their own data, and they would see themselves in it. But in terms of actual systems that have done particularly well, that's a tough one. I think probably Dr. Kabir can give us a good sense from Bangladesh. That is quite an excellent example of how we brought in the mobile technology to connect with the community.
So I think because the community workers we have been discussing about in Bangladesh are employed by government and they are public sector employees. So, and usually they would know each of their clients, and they have what we call rounds. They are supposed to visit those communities. So they start with actually making registration, and also they are known to their clients. So there is really a link between having a good system and recording, which existed in paper. We have just replicated it in a digital tablet. So actually we have followed the way they work, and the benefits came in terms of data quality and the work which was repetitive, and they used to actually do a lot of calculations. They were relieved of this. So, and also the community also value this because they provide actually data and they take services. So there is good interaction between their clients and the community level workers. So this is, I think, I would flag this as very important. And also the managers and supervisors are also making sure that they visit those places and also capture all the services provided to the clients, and those are reported regularly on time, and they can see actually. I think the digital system is makes it very easy to, when you are supervising a lot of workers, you can it become very difficult if you have to visit, but if you get all the results online in a web view, it becomes very easy to actually monitor your workers.
Okay, thank you. I think that's about all the time we have. We borrowed a little bit from the next hour. So Matt, could you go to the next slide? Just to summarize, we've had some really interesting presentations and discussion regarding RHIS strengthening. And, of course, the aim is to improve data quality, data use, all for improving health outcomes. And, I think we've seen a wide range of strategy use, to developing and customizing platforms, approaches to interoperability, deploying and scaling up. But that brings up a lot of issues, especially in terms of capacity building, and then this issue of data quality audits. And also, I think we've seen that, success depends not just on technical and IT factors, but also there's a lot of behavioral factors, organizational factors that come into play: leadership, mentorship, supervision, building a culture of data use, trust. And there's probably a lot of work needed in terms of building trust in the systems about data quality, and that will facilitate much greater use of data for decision-making. So I really want to thank the 5 presenters. That was really interesting to hear about all of these different wide-ranging experiences on data use and your experiences. Mike, I'm going to turn it over to you for the research panel, so we'll look forward to that.
Hi, thanks very much, David. Again, I want to echo David's thanks for all of the great presentations in the first half, talking about these really incredible systems to generate a large amount of data. And in the second half today, what we're going to do is go into some examples of how this data that's being collected in so many places can get translated and used by researchers to come up with policy actionable messages. And this is a really exciting time for those of us like myself that use routine health information systems for your research, because the data has really gotten to a point in a lot of places where it's rich enough and complete enough that you can generate really interesting and solid research findings from it. So what we've put together today is 4 researchers who've used these types of systems as their primary source of data in recent health system research projects. And they're going to share their experiences with you of having used this data and show you some of the results so you get a bit of a taste for how these studies look. So if you can go to the next slide, Matt. I'm going to introduce you. So our first panelist in this session is Matt Wargis, who's a PhD candidate at the School of Public Health and Tropical Medicine at Tulane. And he's going to talk to you about some recent work that they've done with routine health information systems in the DRC.
Thanks, Mike. My talk is called Utilizing DHIS2 Data from the DR Congo for Health Systems Evaluation. So I'm going to focus on an impact evaluation that we are currently conducting, as well as some factors we considered when selecting DHIS2 data elements for use in our evaluation, and the crucial steps that we took to clean and process these data. So the D4I team was tasked by USAID to conduct an impact evaluation of health system strengthening activities currently being conducted in the DRC by the USAID Integrated Health Project, or IHP. So this project aims to reduce maternal, newborn, and child deaths through delivery of integrated health services. And the primary objectives of the IHP are to increase access to and use of health services in the health zones targeted for action. So as part of our evaluation, D4I posed the following research question. What was the impact of the IHP on the utilization of health services over the course of the study period? So as an example, did clinic attendance for treatment of certain childhood illnesses increase or decrease relative to non-intervention sites as a result of the work that the IHP is doing? So the analysis approach the D4I team settled on was a difference in differences with propensity score matching model. And of course, we use DHIS2 data for this analysis. There are other and related aspects to the impact evaluation that I won't discuss here, but note that the D4I project has also relied on primary data collection through quantitative and qualitative studies. So I just wanted to say a quick word about the propensity score matching approach that we used to identify control health facilities through the use of DHIS2 records. So we extracted a multi-month pre-intervention time series from the DHIS2 for facilities that would eventually be included in the treatment health zones, as well as those outside of the IHP targeted health zones. We were able to make use of dozens of DHIS2 data elements to align control and treatment facilities with similar characteristics as far as clinic attendance rates across these specific data elements. The overall pool of matched control facilities serves as the comparator against those facilities receiving the IHP package of interventions while still ensuring similar baseline characteristics. So besides the ability to conduct propensity score matching, why else would we use DHIS2 data? Well, there are several advantages, including access to a wide breadth of data elements that cover an array of health service areas. These data can also be analyzed at different levels of the health system, from the facility to the national level. And generally, DHIS2 data are collected through the use of standardized reporting tools on a regular basis. And because of this, we were able to conduct frequent updates to our analyses. However, not all data elements are well reported, and it's typically necessary to process and clean DHIS2 data. So one of the first things we did before beginning our impact evaluation was to identify well-reported data elements. This was a little tricky using the DRC's DHIS2 data because the system doesn't include zero counts, making it difficult to discern between truly missing values and those that should otherwise be considered zero. So I'm showing here on this slide 3 data elements from the DHIS2, each of which is depicted for the same 4 months. You can see the differences as far as the percentage of missing values, which are all depicted in black. But just because some of these facility data points are empty, that doesn't necessarily mean that they should be considered as truly missing. They could just be unentered 0 values. So I'll speak to a method that might help to account for this issue in just a few minutes. Another important step we worked through was establishing how recent our time series should be, which is to say, how long should we wait before pulling data for months immediately preceding the current month? So it's easy enough to assess this question using a subset of consistently reporting health facilities from an earlier time period. So here on this slide, I wanted to figure out when it would be good to pull September and October data. So I identified 6 months of data from earlier in the year, where all the facilities reported a value for each of these 6 months, those in green here, and this is total clinic visits. It was then a straightforward approach to determine the percent of those same facilities that had reported data for September and October. So in this example, I might wait maybe a week or so before using September data, which has 85% reporting completeness for these facilities. And I wouldn't bother yet using October data, which only has 15% reporting completeness. So like I mentioned, some information systems do not record 0 counts in order to save space. At least with the DRC data, there are inevitably health facility records with no data across a time series depicted here. And I just dropped these records straight away. One approach to filling in remaining missing values would be to assess a suite of data elements for the presence of a value at a particular time point, the same time point across each of these data elements. If one or some of the records have a value but others don't, you could assume that the missing values are actually 0 counts, shown here, and just fill in the blank with a 0. Before taking this approach, you should of course ensure that all the targeted data elements are indeed routinely reported. So there will also inevitably be outliers in your time series due to transcribing errors or data entry errors, or they may just be legitimate outliers. Considering how your time series behaves may dictate the level of sophistication necessary to identify and remove these outliers. You can see in the image here on the bottom of the slide that there's a seasonal peak, pretty obvious, as well as a gradual or slight upward trend in the overall time series. I used a special statistical package to take these time series attributes into account, which ended up identifying, in this particular example, 3 outliers, those in red right here. Outliers could just be removed from the time series before conducting some sort of imputation, for example, which is what the next slide covers. There are several methods for managing missing data, depending on the degree of missingness in your time series and based on your understanding of why the data are missing, is it random or not? You may just consider dropping any records that have missing values for what's called a complete case analysis. Based on my experience using DHIS2 data from the DRC, missingness is complex. And if you're not a statistician, it might make sense to consult one for advice on how to move forward with this particular step if you choose to apply it to your data. And that's just good advice across the board. Consult a statistician, or at the very least, read what other researchers have done to process routinely reported data. So that's all my time. I really just wanted to present some of the major issues you might encounter or specific steps that you might consider as you work to process and clean routine data.
Thanks very much, Matt. That was a great introduction to some of the issues working with this data. I'll just note for everybody that we did mark all the questions from the first half as answered. So they do still exist, but we want to get questions for the research group as well. Our second panelist here is Celestine Hategeka, who is a postdoctoral fellow at the Harvard T.H. Chan School of Public Health. And Celestine is going to present to us on some work that he's done in Rwanda using the data from their routine health information systems.
Thank you very much, Mike, for the introduction. So hi again, everyone. I'm very pleased to present the work we did looking at the use of routine health information system data to study health system quality. This is really important as previous speakers have already mentioned. So routine health information systems has been expanding across low and middle income countries. And we know that there is mounting evidence suggesting that for these countries to achieve SDG goal, specifically those related to health, we really require high quality healthcare systems. So we want to know if this expanding routine health information system could be used to study quality. Next slide, please. Oh. So we specifically looked at the routine health information system in Rwanda called Rwanda health management information system. We used the framework of high quality healthcare system proposed by the Lancet Commission on high quality health systems. Specifically, we looked at the reporting forms at the health center level and the hospital level for looking specifically at the process of care subdomains. Those includes competent care, competent systems, and the positive user experience. As for the quality impact subdomains, we look specifically at health outcomes. Those include mortality and morbidity that are sensitive to high quality care. We looked on people's confidence in healthcare system, and lastly on measures of economic benefits. For example, whether systems captures indicators such as financial risk protection to ensure that users do not suffer from catastrophic expenditures. Next slide, please. What did we find? We found that the reporting healthcare systems in Rwanda at the health center level, they capture over 500 indicators, whereas at the hospital level, over 700 indicators are captured. Overall, about 30% of indicators collected are a process of care or quality impact indicators. So looking specifically at each subdomains, we can see that as shown by green color, that's where at least one indicators was available for these subdomains, and the red otherwise. You can see that now, indicators within the care and the system competence are captured across hospital and the health center reporting form. However, most of these indicators, they capture, they are related to maternal and child health. When we look at quality impact, we can see that health outcomes metrics are largely captured across all level of care. However, there is no indicators on people's confidence in healthcare system nor economic benefits. Next slide, please. So using the available indicators, we assess longitudinal changes in quality of care in Rwanda to really identify new potential efficiency to guide quality improvement. We use data from 2012. That's when the system changed to a DHIS2. We did this to ensure consistency and to avoid information bias. Specifically, we looked at process of care indicators, and quality impact indicators. So we use time series analytical approaches to analyze the data as a consecutive observation, which in case of Rwanda HMIS are monthly aggregated data, they are likely to be affected by to be correlated. So we adjusted for autocorrelation as appropriate, and also seasonality where it was significant. So given the free various level of healthcare system in Rwanda, we stratified by our analysis by level of care. So there are free level of care, the lower level that includes health centers and clinics. The secondary level, it's largely consists of district hospitals, and the higher level consists of teaching hospitals. So next slide, please. So for today, I will provide examples of our findings, focusing on what we found at the secondary level of care. For process of care, looking here, we looked at a composite process of care index consisting of 7 indicators spanning intrapartum and postpartum care continuum for maternal and newborn health. And we found that baseline quality of care was just over 60%, and its trend increased significantly during the study period. Next slide, please. So for quality impact, we looked specifically on at maternal health outcomes, specifically looking at obstetrical complication case fatality as an example here. So as you can see, the baseline obstetrical complication case fatality at secondary level of care is about 76 maternal death per 10,000 obstetrical complication, and its trend really decreased similar to what we saw in the process of care significantly during the study period. Next slide, please. Similar to what we observed on a maternal health outcome, here we looked on a newborn and child health outcomes. As you can see, neonatal and pediatric mortality decreased significantly. As you can see, the neonatal mortality had the highest baseline. However, it also registered the highest decrease during the study period. Next slide, please. We also really interested in looking beyond the maternal and child health. We looked at specifically in patient mortality in internal medicine and the surgical departments. We found that in patient mortality decreased, although modestly, but significantly in internal medicine during our study period. However, surgical related inpatient mortality did not decrease. Next slide, please. Similar to what we observed on surgical mortality, stillbirth rate did not really decrease significantly during the study period, except the changes that were due to shifting in the case definition. So you can see on this slide, the case definition of stillbirth in Rwanda changed around the beginning of 2018. So it used to be defined as any stillbirth with a gestational age of over 22 weeks. And then from 2018, it changed to a gestational age of over of 28 and over. This led to a significant drop in stillbirth rate, largely driven by a drop in intrapartum stillbirth rate. However, this change, when you adjust for this drop change due to change in case definition, we can see that overall stillbirth rate did not change during the study period. Next slide, please. In short, we found that the current routine health information system in Rwanda, it captures limited process of care and quality metrics, and they focus mainly on maternal and newborn health. Indicators are relevant to positive user experience and the confidence of people's confidence in healthcare system and economic benefits were not captured, and it will be helpful to add those in the future. Using the available metrics, we found that the quality of care provided in the Rwanda health facility largely improved over the study period. However, there is still a room for further improvement. Specifically, they need for a specific intervention targeting stillbirth and also quality of care for patients with surgical condition. Next slide, please. I would like to acknowledge and thank my co-authors and funders and actually the Ministry of Health that really provide us access to this data that made this study possible. Thank you very much. This brings me to the end of the presentation.
Thanks very much, Celestin, for a really interesting talk. Next, we're going to see some more data from Rwanda, where Mr. Hinder Rutan, who's a faculty member at the University of Rwanda, is going to present some research on Ebola epidemics in the DRC. So, Hinder.
Thanks, Mike. For this presentation, I'll concentrate on the Ebola outbreak that took place in the province of Equateur in the DRC. Next, please. So from previous outbreak, those major outbreaks led to widespread disruption in health system. For example, the 2014 and 2016 Ebola outbreak in the West Africa led to an increase in mortality. So therefore, there is a need to put in place or implement policy that will help mitigate the disruption of health service use. So in that regard, the government of the Democratic Republic of Congo, with the support of the World Bank, put in place a temporary free care policy in some health zone in the province of Equateur between June and September 2018. Next, please. The objective of our study was to estimate the impact of this policy. So in so doing, the goal, our intention was to try to assess the change in level and change in trend in the rate of utilization of health services in primary health centers. Next, please. So to do that, we used a control interactive time series. It's one of the strongest quasi-experimental method, and when you're using a controlled one, you're able to isolate to some of the bees. And I could cite probably one of the most important one would be history. If something happened in the intervention zone or the control zone, you'll be able to isolate for that threat. So the intervention in this case will be the implementation of the free care policy. Next, please. So in the province of Equateur, which has 18 health zones, in 3 of those 18 that were Ebola cases were localized. So the government implemented free care policy in those 3 zones, but as well in 4 neighboring health zones. So this gives us 2 intervention groups, health zones where the Ebola cases were localized and where the policy was implemented, 4 health zones where neighboring the health zone with Ebola cases where the policy was implemented, and 11 health zones that will serve as control. Next. So in so doing, we used HMIS data, and as the previous presenters have explained, the data has some limitation, and we use some of the technique suggested to we remove some facility with 2 or more missing reports. And as well, we trying to look for outliers. We use a different technique whereby any data point which was 8 standard deviation above the mean was removed as well. To model our data, we use a 2-level mixed effect negative binomial model that would help us adjust for clustering observation and correct for overdispersion. So as you'll see in the next slide, we had 3 time periods. The pre-intervention period from January 2017 to March 2018, the intervention time when the temporary free care policy was implemented from June 2018 to September 2018, and a post-intervention time after the temporary program stopped from October to January 2019. Next. As you'll see, and again, that's one of the beauty of using an interactive time series. It's visually really appealing. You can see a lay audience would easily see whether or not the intervention had an impact. So again, I didn't talk about it, but it's a good time to talk about it. So we removed 2 months, April and May, where the beginning of the implementation of the free care policy, which coincides with the beginning of the outbreak. So the time was too short for us to properly independently assessing the time trend. So we decided to remove those 2 months in the analysis. So overall, the rate of utilization of care in the intervention group will increase statistically. Next. And that was the same for the maternal health, especially for the first ANC visit. Next. And that's also the same for the first dose of DPT vaccine. Again, as you can see, when I was saying that this is really, really appealing, you can see that the green one, which is the control, before and after the intervention, nothing changed, right? So that also helps convey the message and as well help isolate some of the threat of validity. Next. So, as you can see, the free care policy implemented during the Ebola outbreak led to a large increase in utilization of healthcare. The magnitude was similar in the zones, in the Ebola zones as well, and in the zone with no Ebola, neighboring the Ebola zones where the free care policy was implemented. But again, the presentation is only for a short time. I didn't present everything. The change was not was different, was not equal in all the indicators we chose to do the analysis for. I would we publish a paper in July. I would probably share it for anyone who would be interested in looking further. My last slide, please. So I'd like again to acknowledge co-authors, especially those who led this project, Dr. Kropan and Mike Lowe, as well as the Ministry of Public Health colleague who provided the data, as well as the founder. Thank you very much.
Great, thanks very much, Henda, for a really excellent talk. Our final talk in this session is going to come from Ruth Ashton, who's an infectious disease epidemiologist and research assistant professor at the School of Public Health and Tropical Medicine at Tulane. Ruth's going to present a couple of examples to us on some work that she has done in Zambia using routine health information systems. So over to you, Ruth.
Thanks. So before I get stuck into the presentation, just to say, these results are based on work that I and that others have been doing in Zambia. So we've been working very closely with the National Malaria Elimination Committee, and also PATH Masepa is one of our key collaborators in Zambia. Next slide. So coming from the malaria world, there's a few reasons why using routine health information system data is really appealing for analysis. And perhaps the most important is that this expansion in health information systems has happened at the same time as a huge expansion in access to confirmatory diagnostics. So that means that now, as opposed to maybe kind of 5 or 10 years ago, any patient who has suspected malaria is going to be tested either by microscopy or with a rapid diagnostic test when they seek treatment, everywhere from specialist hospitals down to community level. So that means that the data that we have available within health information systems relates to confirmed malaria cases. So this allows us to get much closer to understanding incidents within our communities. Another really important point is that as health information systems have been developed and developing in many countries, is that we increasingly are seeing other data coming into that system as well. And this speaks to some of the presentations in the first half of this symposium. So in malaria, indicators that we see increasingly being available are things like numbers of mosquito nets being distributed through continuous methods. So this might be nets being given out during routine vaccination campaigns or being given to pregnant women during their antenatal visits. And we also have data on other interventions such as intermittent preventative treatment in pregnancy. So this RHIS ecosystem is really starting to be able to give us lots of different indicators that are useful when we're looking at malaria impact analyses. Next slide. So the first study I wanted to highlight is a really nice piece of work that's been led by Maya Fraser and colleagues. This essentially uses an interrupted time series with a comparison group. So this is quite similar to the work that you just heard Henda talk about. The really interesting thing here is that they modified the method or took advantage of almost a regression discontinuity approach to this analysis. So in a small number of districts in southern Zambia, where they're aiming for malaria elimination, they piloted and are now kind of on a semi-regular basis doing mass drug administration for malaria. And the strategy to target which health facility catchment areas received MDA was based on the malaria incidence. So they used a cutoff of 50 malaria cases per 1,000 population per year. So the ITS method actually used health facility catchment areas which were just on either side of that threshold. So our assumption here is that those catchment areas would be very similar in all other kind of categories and all other transmission, all of these things, apart from whether or not they received mass drug administration. So this allows you to essentially run your interrupted time series, comparing those areas that received MDA to those areas that didn't receive MDA. And this allowed us to, or allowed the researchers to explore the impact that they feel that they can attribute to the mass drug administration alone. And they saw a 46% greater decrease in malaria incidence immediately post MDA compared to in the comparison areas. I'd encourage people to take a look at this paper. It's a really nice example. It's in the Journal of Infectious Diseases. Next slide. And a second piece of research from Zambia that I wanted to talk in a bit more detail about used a slightly different approach, a dose response analysis. So the research question here was to try and understand how an expansion of community case management of malaria has had an impact on malaria burden within the community. So the figure on the right-hand side, you can see this is just the number of community health workers operating in Zambia from 2015 through 2020. So you can see there's been a kind of gradual increase from almost no community health workers operating to more than 4,500. So a large expansion in this intervention across many parts of Zambia. One of the challenges with this kind of intervention where you're increasing access to care and you're potentially increasing the number of diagnoses and the number of cases is that you have potential for bias if your outcome indicator is malaria case incidence. So if you have more community health workers, more people seeking treatment, you're potentially expecting to see more cases. So that becomes very difficult to explore the impact of this intervention on malaria. So we instead took a slightly different approach and decided to look as our outcome at severe malaria. So our hypothesis here is that if we see an increased access to services through these community health workers, there would be a reduced time for a patient from when they become ill to when they seek treatment. And by reducing that time for them to seek treatment, you're reducing the likelihood for any of these cases to progress into severe malaria. So our research question was really, after accounting for other malaria interventions that are taking place within this population and seasonal variations in transmission, is this expansion in community case management of malaria associated with a change in the severe malaria incidence rate? Next slide. So for this analysis, we were able to use routine health information system, both to define our exposure variable and for our outcome variable. So for our exposure, we're interested in looking at the number of malaria service providers per 1,000 population. And this is a combination of community health workers as well as the existing health facility infrastructure. So the figure on the lower left, you can see the change over time in the number of providers within Zambia. And then for our outcome indicator, we were looking at the inpatient malaria admissions and inpatient malaria deaths by district, by month from this period from 2015 to 2020. So we were making the assumption here that this inpatient data was representative of the severe malaria cases occurring in the community. Next slide. So the approach that we took for the analysis was to use a dose response. So this methodology, essentially, it just takes advantage of the natural variations in your intervention or your exposure intensity by district and also over time. So the figure on the right shows by district in Zambia, the number of providers, malaria service providers per 1,000 per district in 2015, and then in 2020. So you can see there's quite a stark difference as a result of this expansion of community case management. And just a few technical details. So this dose response method used negative binomial models with random effects. We included indicators to account for vector control, for rainfall, and also for population. Next slide. And so the results were very promising. So we found that adding one additional malaria service provider per 1,000 population was associated with a 17% reduction in the rate of malaria admissions in children under 5, and a 24% reduction in the rate of malaria deaths among inpatients less than 5 years. So these numbers can sometimes be a little bit more difficult to interpret, especially if you come from more of a policy angle than a research angle. So one of the ways that we further developed this analysis to try and provide some really clear messages for policymakers was to attempt to answer the question of at what level of malaria service provider do you really start to see this large impact on severe malaria? So to do that, we took our continuous variable of providers per 1,000 and categorized that to try and see at what level you start to see this really strong association. And what we found is when you have more than 1.75 providers per 1,000, which is about 1 provider per 570 or per 600 people, you see a really strong association between reductions in inpatient malaria admissions and then in malaria deaths. Next slide. And so just to summarize, and some of these methods have been mentioned by other presenters as well. So interrupted time series analyses and dose response, I think are really powerful tools when you're using routine health information systems data for impact evaluations. The ITS approach is really useful when you have an intervention or a policy change that occurred on a specific date and affected a wide range of places. The interrupted time series can be used with or without control or comparison areas. But one of the key assumptions of this method is that it assumes that your intervention has been applied with a consistent intensity across all areas, and generally that intervention remains consistent over time. By comparison, the dose response analysis is useful when you don't have a clearly defined interventional control area, but instead what you do have is a variation in intensity of whatever policy or intervention that you're interested in. So you can use that difference by district to explore the impact that that has on your outcome. One of the key limitations for a dose response method is that it's prone to confounding if your intervention intensity is associated with your outcome. So that's just something to be careful about. If you're interested, especially in the malaria angle of these issues and how to use routine data and evaluation, there's a couple of papers that I've worked on with colleagues that I've added the references for here. And next slide. Okay, and I'll hand over for the Q&A. Thank you.
Thanks very much, Ruth. I'm just going to get my video started again here. So I'd encourage people to submit questions for everybody on the site if you have them. And thanks to all the presenters for really interesting talks. I'm going to start. There's a couple of questions that go along a similar theme about doing these studies and what you do with missing data. So I'm wondering if anyone wants to comment on how you dealt with missing data and if there's any good resources to do that. And I guess more generally, just what resources did you find helpful when learning to work with this data in the first place? So Matt, do you want to start there? Because you did talk about that issue.
Yeah, I mostly went straight to the literature and tried to find examples or just guidance documents that have been published either through journals or just organizations that release information online to see what the community kind of does in general as far as missing data. There's a lot of assumptions that you need to consider. First, exploring your data to figure out, I suppose, if your understanding is that it's random or not, and there's a whole mess of techniques that you can apply. And I think that you just have to get your hands dirty with exploring the data as they are, figure out kind of why or why not there are some missing data and go forward from there with this suite of methods that you can use to handle this notion of missing data. One of the major issues that we had was trying to figure out, like I mentioned in my talk, whether it was a truly missing value or a zero value. And it's kind of an assumption that you need to make about how you're going to move forward with that. But I mean, without getting too technical, that's just what I would say is read and look to the literature to see what exists.
Celestine, Hinder, or Ruth, any of you want to add anything there?
I'll just add as well that I think what's really important is, as Matt said, to look very closely at your data, talk with people who are very closely involved in collecting that data and understand what might be some of the drivers of missingness in different areas and how that might differ in different places or over time. And also to think about how those possible missingness in that data might bias your interpretation of your findings. So I think it's easy to get caught up in trying to develop the perfect data set, but as long as we understand as much as possible what possible limitations there are in our data and how that might bias our interpretations, I think that puts us in a fairly strong place to be able to move forward with the analysis.
That's great. For the next question here, I have a question that's specifically for Hinda. Carrie Westgate asks, were you able to assess equity impacts of the free care policies in the DRC? And if so, what kind of indicators did you look at?
Can you repeat again?
Were you able to assess the equity impacts of the policies that you were, of the free care policy that you looked at in the DRC?
No, unfortunately, that's one of the limitation of using a routine health information system. As Celestine presented, you can only deal with what you have. So yeah, we used data element, and I don't think any of those data elements would allow us to assess equity.
Mm-hmm. Ruth, I think this question's specifically for you. Shirley Ann asks here, for the dose response analysis, what was the statistical analysis method that you utilized there?
So we used a negative binomial mixture model. Negative binomial because our data were over-distributed. So working with count data, obviously this is a fairly common thing to see. And the mixture model because we were working with repeated observations from districts over time. So we included a district random effect to account for that. But unlike with the interrupted time series, maybe this is like a technical debate, but you don't necessarily need to include a kind of temporal autocorrelation because you're just looking at the association for each district and each month between the dose of number of providers or whatever other exposure you're interested in and your outcome, which in our case was severe malaria cases.
Great. There's a question here from Adovich Rivera about deduplication and re-identification. Did any of you use individual level data in any of these analyses, or are they all aggregate?
Yeah. Let's go for it.
So I was saying, I guess they were aggregate. Those are available in Rwanda. I guess some other people may tell us what happened on the other side in DRC or Zambia.
Yeah, in DRC it was aggregated as well.
Yeah, I think the vast majority of data that's available from routine data systems is still aggregate level. There's a few exceptions. I know in the malaria world, there's places where they're doing individual level data specifically in elimination areas. But I would say that's the exception, not the rule, in terms of how the types of data are usually available for analysis.
Mm-hmm. Great. So a question here that I put up. So what features of your studies do you think have been most compelling to decision makers? You know, like some of the results that you all have presented are very graphically compelling. And so I think that's part of it. But what aspects really help change your guide policy in the respective places that you've worked? And Celestine, can I start with you? Because you haven't had a question yet.
Yeah, great. Thank you for the questions. Well, I guess one of the important feature of things you need to remember, I guess, that I employed in this analysis or approach in these studies, it's to involve all stakeholders, namely locally those who are likely to use the data. So designing, analyzing, and mostly even when I was at the interpretation level, remember I working back and forth with colleagues in the Ministry of Health and other clinicians who are likely to be using those data. So that helps. So they provide insights on interpretation, but also really it was easy to share our findings even early on before waiting to even submit for publication, so they can use them early on to inform a design of improvement strategy.
Ruth, Matt, or Hinda, would anyone like to add to that?
Yeah, I think from my perspective, whenever I see a report or a paper that's pretty transparent in the methods that they use to prepare the data before they actually did their analysis is the way to go. And I think if you're applying some of these techniques, for instance, removing outliers, for example, and even if this is just a throwaway sentence in a report or something, describing how that changed the missingness in the data. Did it change it by 20% or only 5% or something like that? I think having those details and being transparent will help to instill confidence in the people that are reading through your work.
Ruth, did you want to add anything about working with policymakers?
I mean, I think some of the key things are really to have an ongoing engagement with the policymakers and the M&E teams or the surveillance teams who work with your data on a regular basis. Engage them right from the start when you're thinking about what research questions might be interesting. Make sure that they're involved in the methods and understand the methods. And when it comes to presenting results, I think it can be easy to get tied up in the very kind of technical output. But sometimes as researchers, we need to take a step back and make sure that what we're explaining and presenting is understandable for people who aren't necessarily specialists in that method. So thinking about ways that you can present your results in a way which is still technically correct and doesn't violate any of your conditions of your analysis, but is more digestible as like bite-sized information. So whether that's key messages about whether or not specific targets that might exist in national strategic plans have been achieved or not, or offering recommendations on, I think in our example from Zambia, the number of providers that you should aim to have per district. So having some of those kind of tangible outputs that can feed directly into policy can be a lot easier than saying we had an incidence rate ratio of 1.73 or something. Making sure that we're packaging information in a way that's easily digestible.
Mm-hmm. Those are great suggestions. And Hinda, did you have anything you wanted to add to that list there?
Yeah, it's not in DRC, but especially in Rwanda, where I'm from, and where I have better contact with the policymakers. As Ruth says, and everyone, engaging them well ahead of time is very, very important. And one of the outcome of this engagement is the needs from the healthcare authorities in Rwanda and keep doing this type of analysis. And Mike and myself as well have been contacted to keep conducting training. So, and myself, like these days, we are doing some, from the request from the Minister of Health officials, senior officials, to evaluate the impact of COVID on existing services. So just to emphasize how important engaging health policymakers is key to in this exercise.
Great, thanks very much. There's a question here about data mining techniques. Did any of you use data mining or machine learning techniques in any of this work? Matt, I'm getting a nod from you. So do you want to answer what the role of data mining might be here?
I think this falls into the category of machine learning, but when we were doing propensity score matching and trying to find the optimal covariate structure in our model, we used a generalized boosted model. And the only, well, a major drawback to using GBM is that you don't, at least the package that I used, you don't get a final model. There's no way to really understand the final model specifications with respect to interaction terms or polynomial terms, etc. But using that method definitely gave us an optimal output compared to me just manually trying to establish a covariate structure in our models. But that's right now the extent to which I've used machine learning for these data.
Mm-hmm. So Matt, can you advance me to the next slide here? And I'll just wrap us up quickly. So in terms of a summary of the key points here, just to come back to some of the key lessons I think I take out of the research half here, is that there's lots of possibilities. You know, we have, even just in this session today, seen a whole range of different study methods, such as descriptive studies, time series studies, interrupted time series analysis, differences in differences, dose response. So you see that there's a huge range, and there's a lot of things that are becoming possible with these data that are becoming available. And this is only going to increase as we get better electronic medical records and other data sources that become linkable and analyzable. There's a lot of strengths that you can lean on when you use routine health information system versus other methods of data collecting like household surveys. They're quick because you just take them from the existing data system. They're cheap because they've already been collected and they're already in existence, so you don't have to pay for that data collection. They're longitudinal, so you can look back in time and look at the effect of a policy on an outcome over many, many years in some cases for the RHISs that have been in place for a long time. And I think the other strength here is that they also demonstrate the value of the data. You know, a lot of money and resources goes into the collection of these data sets, and being able to show the impact of programs with that data really does demonstrate the value of collecting that data for policymakers and decision makers. At the same time, I think a lot of our panelists today presented some of the limitations with the information. There are persistent data quality issues, even in the countries that collect these with the most rigor. So you do need to be cautious in that respect. Sometimes they have limited variables in terms of not having exactly what you want. They often have missing data, and so we already have had the discussion about what one needs to do to think about that. They can have changes in data definitions, as Celestin showed in his presentation. A change in the data definition can radically change the numbers that you get in your data set. And a lot of the times these require more sophisticated research designs. You know, for those of you who aren't from a quantitative background, there's probably aspects to each and every one of these presentations that sounded like Greek, mostly because it is Greek, it's statistics. But it takes some time and some work to really learn those research techniques. It is possible, but it does necessitate it. So you need to be careful. You need to understand your data really well. I think that's a point that Ruth brought up. Understanding it and working with the people who developed it is really important. And you need to make sure that you use appropriate methods in the analysis. So Matt, next slide, please. I want to take the opportunity to thank everyone. This was a really excellent session. I learned a lot from everyone, and really enjoyed all of the presentations. We've put everybody's contact information here. So if you have follow-up questions or want to seek more information, then please feel free to reach out. And thanks as well to David Hotchkiss, my co-chair for the session, for all of the work that he did leading this effort and putting this together. So with that, I'll thank everybody and look forward to interacting with all of you at the rest of the conference.